HPI stands for Hypertension Prediction Index. This is the hemodynamic variable designed to predict intraoperative hypertension, defined by a mean arterial pressure below 65 mm of mercury for at least 1 minute. In practice, the HPI cutoff value of 85 has been proposed to forecast hypertension within the next 5-15 minutes and invite clinicians to be proactive by giving fluid or vasopressors. HPI is calculated by a machine learning algorithm that was trained using a large number of arterial pressure waveforms. Despite the complexity of the algorithm, the main information learned by the algorithm seems to be the following. When the MAP is close to 65, let's say 70, hypertension is more likely to occur than when the MAP is far from 65, let's say 80 or 90 mm of mercury. Indeed, many examples of very tight relationship between MAP and HPI have been published. This relationship varies from one patient to the other, but is always tight, such that the lower the MAP, the higher is HPI. This explains that HPI trends are the mere reflection of MAP trends, what has been described as the mirror effect, and is visible in many publications and at the bedside. In short, most of the time HPI is 85 or above as soon as the MAP is 71 or below. As a result, the predictive value of the MAP is expected to be comparable to the predictive value of HPI. It was suggested by this study and confirmed by this other. We need more data comparing the predictive value of HPI to the predictive value of the MAP. Does HPI predict hypertension? Yes, not as well as suggested by first studies because of a selection bias, which has now been described in detail in several publications. But yes, HPI can predict hypertension. However, there is no evidence that it is a better predictor than the MAP. Is giving fluid or vasopressors when HPI above 85 useful to decrease hypertension? Yes, as would be the administration of fluid or vasopressors as soon as the MAP is 71 or below. Clinical studies comparing these two strategies are warranted. Is the prevention of intraoperative hypertension useful to improve postoperative outcomes? Here again, we need more evidence, but recent studies have shown that targeting higher mean arterial pressure values during surgery may effectively decrease intraoperative hypertension, but does not improve postoperative outcomes. So finally, is it worth monitoring HPI? We cannot answer these questions before knowing if reacting when HPI is above 85 is better than reacting when the MAP is below 71, and before knowing if preventing hypertension is useful to improve patient outcomes.